Good morning, tribe. I'm here with Tara. She's going to talk to us about wound care. Hi, Tara.
Hi,
How are you this morning?
I'm good. How are you doing?
Good, thanks. Hey, thanks for joining us. I know there was several people interested in chatting with you about your experience in wound care and how they can care for wounds in their personal settings as nurses. So I'm glad that you joined us and brought all your wonderful information to the table. How long have you actually been in wound care?
I've been part of our wound care team for about 2 years, and then prior to that, I was on a floor nurse for a year. So we did a lot
Okay.
of wound care there.
Awesome. What kind of unit was that did so much wound care on your unit?
So I'm in an LTAC, and so the whole hospital, there's a ton of wound care.
Yeah, I'm sure. Okay, that makes sense. So the next question kind of ties into what you already answered, but what did you do prior and how did it prepare you for wound care nursing as it is now?
So that's pretty much it. I've only been a nurse for 3 years, so the first year was just floor nursing and doing all the wound care and just kind of peeking in and seeing wherever I could when the wound care team was in there, because there's a lot
Hmm.
of stuff we do that the floor nurses don't do.
Okay.
So yeah, that's pretty much it.
Okay, cool. Do you feel like wound care is a good place for a new grad to start?
Um, I think that is a great place to be, but I think to start, floor nursing is better just because you have to understand the etiology of the wounds. You have to understand like everything else that's going on with that patient and that it's not just the wound because it helps you to decide what kind of treatments you're going to do. So
Sure.
I think having some time because clinicals is never enough, but
Yeah.
having some time on the floor just to get that basic knowledge and see kind of what's going on with all the patients themselves, I think is
Hmm.
better probably to start.
So
But I
you
moved into
started,
that pretty quick.
sorry, I interrupted you.
Oh, that's okay. I just said, but I moved into it pretty quick. I mean,
Yeah.
truly.
So you feel like a year on the floor was it enough time?
I think so. I think it's a good basis because then I don't know. I still did floor nursing as well as the wound care, and so I continued that. So I wouldn't suggest going into that specialty right away until unless that's absolutely your love. But I think that you still need to like learn and get that background.
Absolutely. I know there's a nurse that is in the tribe, and her goal ultimately, she's an ICU nurse. Her ultimate goal is to open her own wound care clinic as an
Oh,
entrepreneur.
wow.
So, yeah, it sounds super cool, right? I'm
That sounds very
sure.
cool.
Yeah, I was super excited to hear her tell me about that. So, what has been the top three? Oh, no, sorry, I skipped a question. How is the experience? Any insight or advice for someone seeking to go into wound care?
Um, I think it's a great experience. And there's even people out there that I was one of them that didn't think I could do wound care at all when I was in clinicals and stuff. That scared me. Um, but especially working where I work, you get to see these people heal. You get to see what you do make a difference in their lives, and it is
Mhm.
like it's a super rewarding place to be. And so, but I just think that the best advice I could get probably is just to get that nursing under your belt and just realize there's more going on, and there's usually a reason that there's a wound there in the first place, not
Sure.
just that there was a wound. So that's
Okay.
probably the advice I give.
Awesome. And have you taken the wound care certification yet?
I have not. I So there's a couple of different certifications. One of them requires like 4 years of experience, which I don't have yet. The one that I want to get is about 2 years experience. So it's kind of a 2 year full time and then another year part time or something, which is basically what I qualify for now.
Okay.
Um, but there's an expense associated with it, so I kind of have to wait for the hospital. They're going to pay for it, but I kind of have to wait for them to make up their mind to do that because
Okay.
it's about a $3,000 course, and you can take it online or you can go to the facilities. There's a bunch of different places. Nowhere here, of course. I'd have to travel somewhere. And then there's the test that's like $300 or something to take. So it's definitely something I want to do, but I don't have the funds myself, so I'm dependent on them.
Sure. So you said that it requires 3 years experience or more than that. Is that in wound care or is that as a nurse overall?
In wound care, just specifically in wound care. So it said like It was 4 years full time for the one certification, which is apparently a bigger certification. And then it was 2 years full time with 1 year part time wound care.
Wow.
So that's basically what I have. So, I mean, you have to have a lot under your belt to be able to even take this course.
Yeah. Well, that sounds great. I love that goal. Hopefully your institution will get on top of it and realize that that would be helpful for them as well in the long term.
Absolutely.
So what are the top 3 things that made you nervous about the transition to wound care, and how have you met those challenges?
So kind of this, there was a full wound care team when I started doing that. And so what they did was they were just trying to get some kind of all-stars on the floor to kind of help out, because sometimes just emergencies come up with fistulas or wound vacs, and they wanted some other people, especially after hours, to be able to take care of those problems. And so that's when we started, and there was 3 of us that they did that with. And the other 2 just kind of dropped out of it. They didn't want to do it anymore. So, and then when a position came available, then they just put me right in. So I kind of like did this slow transition into it. But I watched everything that they did. When I was just on the floor, if they were doing wound care on my patient, I wanted to know, I wanted to see it. So I just learned a lot. And man, I asked questions. I asked so many questions. I still ask questions.
Yeah.
So if I just don't know, or I mean, there's videos. My manager is awesome. She constantly gives us links to new stuff. She's constantly researching, and so she gives us new stuff. And so we're always finding out new uses, even for the products that we have that we didn't know. So
That's
learning.
great. Yeah, that's awesome, as we should all be constantly learning, right?
Yeah.
So we have a viewer asking a question. We've got several viewers. Hi, guys. Thanks for joining us. So do you have problems with the doctors wanting to still do wet to dry dressings?
We don't. Our doctors are pretty awesome. We have great communication. We have a very small hospital, and we have great communication with them, and they trust us in what we say. So we don't do wet to dries. We have other products that we use, like a hydrogel or these little tender wet magical pillows that are very cool. And so we use those instead because there's less infection associated with that. The Pseudomonas was one thing we were having a problem with the wet to dries. So once the docs understood that, they understand that we know what we're talking about. And so that helps. And so we have really good communication with them. So it's not an issue with us.
Yeah, that's great. The viewer said, thank you so much for answering her question. So let me see, where are we at in our questions? Any insight or advice for someone looking into getting into wound care? I think you already answered that, but do you have anything to elaborate?
That's probably it. It's a learn as you go thing. You're not going to ever know everything. And you kind of just, the first thing I do, like, especially when I get a new patient, is I like to read their history and physical, and then their doctor's notes, just to see like where did they come from? What caused this? What has worked? Because sometimes you get notes from the other hospital that says what hasn't worked, what has worked. Not always.
Yeah.
And then I like to talk to the patient about what they did too. I just get as much information as I can so that I know what I'm actually dealing with. So
Sure.
that just makes it easier to do the job.
Absolutely. So what other tips and tricks do you have? You mentioned the hydro
The
gel
hydro
pillow. Is that what you said?
Oh, yeah, so it's actually it looks like a little mini pillow. It's like a little 2x2 pillow, and it has lactated ringers in it.
Oh,
And so it keeps the wound moist but not wet. It helps debride. It helps mechanically debride. And then it keeps infection out. And it's just like a magical little pillow. And it's so easy to pull out because it just comes out in one piece. It doesn't fall apart or disintegrate in there. Um, so I don't know. Those things are magical, but they don't fit in everything. They have to fit kind of inside. But they make different sizes. That's just what we have.
okay.
Um, but some of the other ones probably, I don't know. I think there was a question about negative pressure, so I guess we'll get to that one later.
Go ahead.
But
Go ahead and answer it.
oh,
It's fine.
so yeah, so I think there was a question about the wound vacs,
Yes.
tips for wound vacs. So one of the things, and this works, this goes for colostomies, this goes for putting bags on fistulas, is using water only. Do not use any soap. Do not use any kind of anything that's going to leave a film. Because
Okay.
what happens is all that stuff goes into the pores, and where that adhesive from whatever we're putting on it would normally go, it's already filled. And so, and that's something that we have to constantly reiterate. And that, I mean, colostomy bags are a big part because people want to clean those colostomy areas with soap and water, and it's such a bad idea. So just warm water and then dry really, really well. And that's like the best trick, I think, for any of these things, because that's a simple, simple thing that you can do that
Mhm.
makes a huge difference with how stuff attaches and sticks.
Wow, that's great advice. That's awesome. Any other tips and tricks of wound care overall?
Um,
I know that's a really huge, broad question.
I know, right? So I think a big part, especially at my hospital, we have a lot of people that come in with a little bit of PTSD from previous wound care.
Hmm.
They go into surgery, they get a wound vac put on, or they get something done, and then the first time it's changed, they maybe have pain medication, but they're not knocked out. And
Right?
so it's it's one of those things that they have a trust issue when they come to us. They're very scared because of their previous wound changes. So we talk to them. We always go in and talk to them before we see if they're even ready for us to do it at that moment. We make sure they're medicated and like really make sure that they understand we want to control their pain. We are not going to cause them pain as much as we can possibly avoid it. Um, so pain management is a huge thing, and just talking to them and putting them at ease, because half the time that's all it is. If they've got a huge wound that is super painful or in a really embarrassing place, or it just helps them if we can really just connect with them first. And so we spend a lot of time with our patients, a lot of time with our patients,
That's
and
great.
I think that that's really important.
So that kind of leads us into the next question. Like, what does a typical day look like as a wound care team?
Okay, so it can actually be kind of a crazy day, or it can go very smoothly because
Hmm.
things come up all the time, especially when wound vacs bust or fistula bags are leaking. So basically, we see we see certain people. I used to work every Wednesday, and so every Wednesday I would see the same people every week because these people at Altac are there for extended amount of time. So I would see my same people. And then I would see people that are getting ready to discharge because we have to see them one extra time before they leave. We take pictures and measurements every time we do this. Um,
Hmm.
and then we also see new admits from the day before, or we can see them on the day. We have like 24, or I'm sorry, 48 hours to see them once they come in. So basically, we start early. I get all my information first. I get everything collected. I get who I need to see. Then I start trying to figure out like who I'm going to see first. If the docs want to see any of these people, what time the docs get here. It's kind of a lot
Hmm.
of organization in the beginning of the day. And then I get all my supplies together, and then I see my people. So I go in, and the ones that I see weekly, they get measurements every single week, and then every fourth week that they're there, they get pictures also. So we do it on admission every fourth week, and then when they leave, and so that way we can see it, and we have them in the computer. Everybody can see their progress. Um, and then, there's all the organization with the getting the nurses for pain management, working around meal times, working around. So I tend to see first thing in the morning, if I get on the floor at 8 o'clock, I tend to see the people who are not eating, people that are on tube feeding or, stuff like that. I
Hmm.
like to jump in whenever there's techs rolling the patient or cleaning them. I just jump in there real quick because I hate moving people when they don't need to be moved extra time.
Sure.
So it's kind of like a just play it by ear type of thing, but I make sure that I have all my information and all my supplies with me first thing in the morning, so that when I go out on the floor, I kind of just can do it and just kind of go by who's ready and who's not.
That's great. So, do you work by yourself then?
Pretty
Along with the other healthcare team members, obviously, but are you the only wound care team member on at the time?
Yes. So what happens is our manager is there, but she has to do all the boring management stuff. She goes to the meetings, does paperwork, all that stuff. So if I need her help with certain people, or if I have a question for her, she'll come out onto the floor with me. Or if we have a really
Okay.
difficult like wound vac thing and I need multiple hands to hold things, she'll come out with me. And so we kind of figure that out at the beginning of the day too. Um, so she's always there. She's there Monday through Friday. And then
Okay.
there's one of us there during the day. Now, currently, right now, I'm actually not even doing wound care. I pick up shifts, but I'm a supervisor now. And so on the weekends, I tend to do wound care because there's nobody there. So I tend to do it in addition to my job. But yeah, there's just generally one wound care person there, and they usually leave by 7 p.m. A lot of times, like right now, our census is pretty low, so they're gone by like 5. So everybody else kind of takes over if they can do it. And so we have kind of backup stuff. If a wound vac is failing and they're not there, they take it down. They do a wet to dry. So temporary dressing is what we call it. We don't like to call it that. But yeah, there's usually just one wound care nurse there each day, and they have the full load.
Okay, that sounds like a lot to handle. We've got a couple comments coming in. So Victoria says rapport is so important in relation to wound care. And then another, let's see, that's Marie. Marie says, wound descriptions are a weakness for me. There are so many terms to choose from, and I usually have to look them up. Do you have any like quick references that you could help us with to help nurses describe wounds more adequately?
Well, so there's a couple of websites, and I can't think of any right now, but they will have like a list and they'll have pictures. But basically, when I was learning, I had a hard time too. I had a really, really hard time, and I would mess it up a lot. But you can basically you have your basic tissue types, and then once you go deeper, it's more of an intense thing. And I don't know how anybody else's system works, but ours, you can look at the previous documentation from wound care, like the last time wound care actually saw them, and you can see what they're saying it looks like. And so it's kind of just you have to just look at it more often. Sometimes pictures are hard, especially drawings. Drawings are real hard. But if you look at actual pictures, if you look at actual wound care pictures of actual people, it's a little bit easier to see it because that's what you actually see.
Sure.
And a lot of times what they're asking for when you're assessing a wound is the worst tissue type. So you might see 4 or 5 different things going on in there, but like necrotic tissue is going to be your absolute worst. Slough tissue, just that yellow dead tissue, but not totally black yet, is going to be your second worst. And then you're going to get like a pinkish type of tissue that doesn't look incredibly healthy, but doesn't have dead tissue on it. That's the next one up. And then you'll have your granulation tissue, which is that beefy red. That's the one that we want to see. And then you'll have that pink epithelial tissue, that brand new tissue. So there's kind of, it's little categories, but you have to just kind of see them over and over and over to really grasp it. But Googling honestly is the easiest way to do that because there's so many different things you can see on there. But if you read the descriptions, sometimes that tells you a lot too.
Read the description from the previous wound care note?
Yeah.
Okay. Hey, Marie, does your institution take photographs of the wounds when your patients are admitted and have wounds? Let's see who commented on that. Victoria said, love to see granulation with a heart. So the last 2 questions are, what do you love most and what's the hardest part of your specialty?
So I think what I love the most is seeing people get better, seeing wounds heal, seeing people come in with huge wounds and then see them actually at least get smaller or to the point where they can get a skin graft or something like that. It is the coolest thing to just see that happen. The hardest part is the other end of that. When we have chronically ill patients who really are not going to get better anyway, and then they've got a pressure ulcer, they've got something, it's not going to heal. And it's so hard because it's so painful for them. And we know that there's nothing we can do. So just keep them comfortable as much as possible. But if you can't heal it, and sometimes they just get worse, no matter what you do, they just get worse. And so we have somebody that's been at our hospital for almost a year. October will be a year. And that happens sometimes. And really, this is a patient that should probably be on hospice because he's got too many comorbidities and he's done. You can tell he's done. It's one of those situations where the family's hanging on. But he didn't have a wound when he came in. But his body was so sick, he got breakdown, and it happened so fast on his bottom. And it just spread. It spread so fast. And so he's had this wound that won't heal for about 6 months. And it's terrible to see that.
Yeah.
But we see more good than bad. We see more healing than we don't.
That's great. Another viewer says, let's see, that's D, says, do you suggest pocket cards with pictures to help with descriptions?
Absolutely. Yeah. If you have stuff like that, absolutely. And sometimes it's still hard to distinguish, but and it just probably depends on the facility you work at, but ours is just, we just are trying to figure out the worst tissue type so we know what to do for it. So,
Sure.
but yeah, absolutely. If you can get pictures, more pictures, the better.
Because that's what you're treating, right? You're treating the worst area of the wound so that it doesn't get any worse, and then hoping that all of it in turn gets better, right?
Yeah, so what you want to do, like especially if there's necrotic tissue or slough tissue, you got to get that out of there or else that wound can't heal. It's not going to. All that stuff is stuck under. So you debride it as much as you can while keeping that wound moist. So it's kind of, it's I don't know, it's a balance. But it's not too hard if you know your products, and that's what the wound care team is for, is to set that up and to keep an eye on it. But we listen to the nurses a lot too. If they notice something's getting worse or if something looks different than it did yesterday, they report it to us right away. We can go and look at it and adjust what we're doing. And it's all about constantly adjusting and constantly, it's like an arts and crafts project and nothing ever goes right. And you just keep adjusting based on that. But yeah, you have to get that wound clean before it's going to do anything.
I have a question, and is there any specific supplement or nutritional guidance that you guys play a part in the education of your nursing team as well as your patient? And is there any specific supplement or diet modification that you find is really helpful? And then someone else mentions here, diet and education is important for healing too.
Absolutely. So we're constantly telling our patients, because most of them, we look at their labs every morning, and a lot of them just get labs once a week. But some of the chronic we look at their albumin levels. That's like probably the most important, that one, and their white blood cell count. And most of them, their albumin levels are in the toilet. Their protein is horrible. They're malnourished. It's just bad. And because a lot of them are on tube feed, and you're just not getting what you need from tube feed. So we have protein packets. We have a couple of different proteins that we do, but there's just like some little gel packets. There's a ton of different kinds of protein, and just depending on what that person is on or if they can handle the taste of it, we do different things to like mix that in. But what we usually tell the nursing staff is just make sure if they don't need anything else in that tray, make sure they eat their meat, make sure they drink that protein drink. We even have like a Crystal Light mixture thing that has some extra protein in it. We've got the Ensure drinks. Like, we have multiple things that we can use, but we put the protein so much that, and we really explain to them that that's the only thing that's going to help them heal. That gives your building blocks. And a lot of them don't know that. They never got told that before. A lot of patients don't know that. And so that education is huge. But we deal with so many wounds that's a big part of what we do at our hospital. So that education is always there.
Yeah. Let's see. I think this is Sarah. Yeah. How do you stay positive in situations with patients that are not getting better? What types of things do you say to the patient to keep it as positive as possible?
So we do like to be as honest as we can with our patients. We'll tell them if there's any little bit of hope, if it's getting a little smaller, if the tissue looks better today, if it's been around, it looks better. We any little bit that we can, but we also have to be very honest with the ones that are chronic. We want to give them false hope about something that's not going to get better. And so we just have honest conversations with them. And the wound care team has that rapport with them to where we can do that. The doctor can't necessarily come in and say, you're just not going to get better. But we can talk to them and be like, look, this is what's going on. This is probably what you're going to be living with. This is what we're going to do to help you.
Sure. All right. Someone says, I know Medline has books with pictures and descriptions and treatment suggestions. I think, who said that? D. And then Victoria said, nutrition it's amazing, and proper nutrition can do what proper nutrition can do for a wound. Protein and vitamin C are easy to increase most of the time. Vitamin C, do you guys use vitamin C as well?
There's a lot of people, I think they automatically just put them on there like a multivitamin. That's not something we necessarily push, but that's not a bad idea. We have a medication. Well, one of our wound care it's called multi-dex powder. It's actually crushed up vitamin C with a little bit of glucose. And actually, that guy that I was telling you about that has been there for almost a year, whose wound was just getting better and better, that's actually stalling it. That's actually, it's giving us a little bit of granulation tissue. It's probably not going to heal it, but that is actually stalling it. Just having that little bit of extra vitamin C in there is helping a ton. So that's not something we have. Yeah, it's called multi-dex powder. It's actually just one of our treatments. But yeah, it's a powder, but it just has the vitamin C, and it's got something else in it. It's got a little bit of glucose. But we have to kind of watch it with diabetic patients. But
that surprises me that it has glucose in it. What's the rationale for that?
I'm not sure, to be honest with you. I think somehow it helps the cells to absorb it or something like that a little bit better because it's topical. But I'm not exactly sure what the purpose is for the glucose. I just know it's not a lot.
That would breed bacteria in my own rational,
right.
critical thinking.
But somehow it doesn't, and it helps to breed. It helps that combination for some reason. Maybe there's enough acidic acid in there from the vitamins that it doesn't. I don't know.
I know glucose also helps with retaining moisture, so maybe that's part of it. Like healthy skin moisture. A lot of lotions and stuff have glucose in them.
I think that's what might help it into the cells a little bit.
Huh, interesting. Well, if we don't have any more questions, I didn't have any more submitted to me from the tribe. And if none of the viewers have any more questions, I think we've covered everything. I learned a lot today. I'm sure you guys did too as the tribe. Any other questions from the tribe as we have Tara here? Tara, I appreciate you taking the time to chat with us and give us all your information. I learned a ton. And if you have any other ideas or anything that pops up, or if you have those resources, if you can think of them, you can just stick them in the comments on your on the link to this Q&A, and that way the viewers can see them.
Oh, okay. I will do that.
Awesome. Thank you. I appreciate your time. You have a good day, okay?
Thank you. You too.
Thank you. Have a good one. See you guys. Bye, tribe.